Well, welcome to another edition of the iTube Journal Club. I'm Chris Starr from the Weill Cornell Medical Center in New York City, and with me is the esteemed Burkhard Dick from Germany, one of the world's leading innovators in femtosecond technology for cataract surgery. And
thank you, Chris, for your very kind introduction.
Delighted to have you. Thank you so much for accepting the invitation. I do want to talk to you. I mean, I would love to talk to you for hours about this topic because it is fascinating and it's cutting edge and it's fantastic, and you've done a lot of the groundbreaking work. But one of the interesting things that you've been doing is posterior capsulotomies using the femtosecond laser, and that's something that a lot of people have not done here. And so, can you talk a little bit about some of your studies and some of your results with this technique?
Yeah, the interesting thing is that the 3D, SD, OCT wasn't available intraoperatively, and usually the case is done. That means you have hydrated or the wound is closed, and what you do now is to redock this eye under sterile conditions. You rescan, and what you see and what we see in a consistent case is that you can see the IOL in the back. You see a clear distance to the posterior capsule, and then another clear distance to the anterior highlight membrane. Right. And that is that's something you can see in more than 70% of your eyes already. The posterior laser-assisted capsulotomy can be done in anybody, but the golden way, so to say, would be to keep the anterior highlight intact. Right. And that can be done in 68% already. And you can then treat this, and maybe you leave some OVD behind the IOL for safety reasons, but it's not mandatory or something like that. But if you may feel, especially for the first cases, you feel more safer, you can do it.
I mean, to prevent dinging the lens with the laser.
Right.
And so, and you're doing that obviously routinely in pediatric patients, but you're also doing it in older patients as well to prevent PCO, basically, which is a very common complication after cataract surgery.
It's more or less the potential is the eradication of PCO, and the potential is to change our attitude and our thinking about cataract surgery. And this is especially true for all kind of lenses. It works with monofocals, with toric, as well as, for example, trifocal toric lenses.
Interesting. And it doesn't affect effective lens position or refractive outcomes, or I mean, I don't think it would, but this is such a novel concept, but in your experience it has not affected that at all.
Not at all, not at all. The interesting thing is, of course, what we are looking at now is safety in this regard in terms of cystoid macular edema, something like that. That's what we have to look at currently, but from my clinical impression, having done this more than 300 times already in the eyes, it is not existent, but that's something we definitely have to look at in controlled clinical trials now.
And in pediatric patients, I mean, it's obviously very compelling. It's been done by hand over the years, and not the easiest. I don't do it myself, but certainly doesn't seem to be the easiest maneuver to do inside an eye. And I'm sure prone to complications, right? The tear going out and difficulties with IOLs. I would imagine the femtosecond laser is much more predictable and much more safe to do it in these patients.
Absolutely. In terms of safety in those 38 eyes in patients we have done already, I would conclude it's absolutely safe. We didn't have any radial tear or any complication. And the good thing is, I mean, everybody knows that the capsule is under that great elasticity that it's always greater than you intend with the manual position. It's also true for the femto, but there is a correction factor we evaluated and elaborated. That means the younger the patients, the smaller you shoot, and the quality of the cuts, histologically investigated, is extremely good. This is true for the anterior as well as for the posterior capsule. And it's also very elastic. That means we can stretch these. For example, true if you implant a femto IOL, which is fixated where the capsules are fixated in the IOL rim, or for example for the bag in the lens, the Tassignon IOL, there it's super, and you can then keep the anterior highlight membrane intact. And you can see it on our YouTube channel. We did it in the live condition, in a live surgery. And it's really impressive, especially for the pediatric. There are some prerequisites that, of course, you need an insurance. It's an off-label procedure currently. You need the permission of the ethics committee, and the laser needs to be in the OR. The procedure, of course, in these 6 to 8 weeks, sometimes young children, is under general anesthesia.
Out of curiosity, a child that young, let's say a 6mm IOL optic, what size do you target on the femtosecond, and what is the size that it ultimately ends up being?
For a 6 to 8 week young patient, we target at 3.7, 3
Wow.
point something, and then we end up at 5.
Wow.
Yeah, and the critical thing, of course, is the interface, because we have, fortunately, we have a small interface that fits through tight fissures, and it's also for Asian eyes as well as for these very young, where any tenths of a millimeter counts.
Wow, that's fascinating. Well, Dr. Dick, I want to thank you so much for being my guest. This is illuminating information.
My pleasure.
And I want to thank you for watching.